What evidence did you gather when you travelled to the Netherlands as part of the Lords Select Committee looking at Lord Joffrey's bill?
When we went to the Netherlands as the Select Committee, I think one of the most shocking things to discover was the number of euthanasia deaths. We learnt that 1 in 32 of all deaths in Holland are from euthanasia. 1 in 38 are voluntary euthanasia. The remainder are made up from ones where there hasn't been an explicit request. And we also learnt that despite their legislation, reporting is still only at 54%. So despite them having all this in place and non-prosecution, 46% of euthanasias are not being properly reported as they should be.
Just to clarify, are they physician-assisted suicides? In other words, do they involve doctors?
Yeah, they all involve doctors. They're euthanasias, mostly euthanasias. As few of them are, a few are probably assisted suicides, but the vast majority are euthanasias, which is where the doctor actually injects an overdose of barbiturate, and if the patient hasn't died quickly, follows it up with curare, which completely paralyses the patient, and then the patient dies basically because they don't breathe, they don't move, nothing, they can't move a muscle. I think the other thing that was of concern was that, to put this in context, if we transfer those figures from Holland to, on a population basis, to England and Wales, we'd be talking about 15,000 deaths a year, approximately. That's a lot of deaths. That's not a small number. That's over 4.5 times our road traffic accident deaths.
Nonetheless, it does seem that the Dutch population are happy with the current legislation. A recent opinion poll suggested that 85% of them support it, and a similar number of people support Lord Joffrey's bill here.
There's been some interesting work done in the States with using focus groups to look at issues around assisted suicide, physician-assisted suicide, what is morally acceptable. And what's quite interesting is that when the doctor is involved, it's viewed as much more acceptable than when you talk about assisted suicide, where somebody takes a massive overdose, but where the doctor isn't complicit with it. So somehow having the physician involved seems to sort of sanitize it and make it more palatable to the rest of the population out there. I think the other thing is, of course, that you have to remember in Holland they don't have specialist palliative care. They have the services that they have. And in the UK, as everywhere, if you look back over the last 30 years, people will have experienced bad deaths in people they love, and they're frightened and they don't want that to happen to them. So this fear of what might happen, I think, is very strong. And indeed we heard in Oregon that some people view it as a kind of insurance policy, that if it all gets too difficult, then they could actually have their physician-assisted suicide. Interestingly, in Oregon, it's only suicide. The doctor doesn't inject you directly with the drugs.
In your own experience as a consultant in palliative care, have you had many patients asking for your help in assisted dying?
I have to say, in all honesty, since 1987, which is when I've been full-time looking after dying patients, I have never had a patient with a persisting request that has gone on for a long time. I have had some patients who have asked, who have expressed a wish to have their lives ended, and the most clear of all fulfilled every criteria in every bit of legislation I have ever looked at, but now is very glad that he is not dead, and says he can't bear to think what would have happened to his children if he had had it.
Many people feel this is already happening in the UK. For instance, when somebody is in distress and dying, and a doctor will just increase the dose of sedation to accelerate their death. Aren't we just talking in Lord Joffrey's bill about pushing this logic one step further?
There is a great deal of muddle between when you end treatment and people die of their disease. They are dying because they are sick. very, very sick, and they are dying of their disease. Now, if you stop a treatment, they may live longer or they may not. But if the treatment is futile, you stop it. If it's not of any benefit to the patient, if it's not achieving its aim. The other thing that happens when somebody is dying is that if they haven't had good symptom control, if they have been in pain, pain is a very powerful stimulant. It will stop you sleeping, it will not let you relax. If you give somebody a dose of analgesia so their pain level goes down, they can relax and they can let go of life. So you have a situation where you've had people who've been tremendously undertreated, and then you give them enough pain relief to just let them have a break from the pain. They're already exhausted, they're dying, they relax, and they die of their disease. It doesn't mean the drug killed them, but in the course of any illness, if you're giving medication of any sort, there will always be a last dose of drug. But it doesn't mean the drug killed them. And we've got no evidence that, given morphine and other powerful drugs in that group, the way that we give them now shortens life. And there is some evidence, if you have good pain control, that you will live for longer, because you aren't suffering the exhaustion on top of the illness.
So clarify for us what is different then about what's being proposed.
If you're giving morphine and other drugs for symptom control, you start low, you titrate up to get above the pain but below the level of toxicity, to get in that therapeutic window. And that's where you want to maintain things. What you do for physician-assisted suicide is you don't use morphine or any drugs like that at all. You give patients a tumblerful of barbiturate to drink, and it's about 50 to 100 times a therapeutic dose. It's a massive overdose of barbiturate. They usually need something to stop them being sick beforehand, otherwise they'll vomit it back. And they drink that all down in one go. So you give them a massive overdose of barbiturate. With euthanasia, you inject them with an overdose of barbiturate to induce coma, then you paralyse them so they stop breathing, and then they die of asphyxia. So it's fundamentally different. You're using a huge overdose of a drug for which there is no therapeutic indication.
Isn't this ultimately about autonomy? Shouldn't patients be allowed a choice about the manner of their dying?
We live in a society where we all interact with other people, and we all have choices to make in life. But the law is there, firstly, to protect the vulnerable in our society. We cannot do what we want to do because it might harm other people. The other thing the law does is it does provide a discipline framework where we know what we can do and what we can't do. The law is very clear. We cannot intentionally kill somebody else. What is proposed is not whether you personally can commit suicide, because you can. It is whether your doctor can act to kill you, or act to assist your suicide in such a way that instead of acting in a capacity to provide care and respect your life, whatever life is left, and that is not prolonging life unnecessarily, that is not sticking you on a ventilator inappropriately, that is about respecting you as an individual. You're saying you're changing the law so the doctor doesn't have to do that anymore. They can pull the plug on a lot of that because they can now be part of ending your life.